Hello, and welcome to the CAP Today webinar for Thursday, November the 5th. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host, and I'll moderate a Q&A session after our formal presentations. We have a very important topic to cover today, and our webinar is entitled Post-transplant viral load monitoring, the importance of standardization and commutability of diagnostic methods. And we do want to acknowledge and thank Roche for their support, as this webinar is made possible by a special educational grant from Roche. We're very grateful for that. We have two speakers today, and I'll say much more about them in due course, but they are Dr. Steve Miller of the University of California in San Francisco, and Dr. Joseph Yao of the Mayo Clinic in Rochester, Minnesota. But before we begin, I'm going to make a few housekeeping comments that I think will enhance your experience. First, we recommend that you refresh your browser. The browser that works best with this platform is Chrome. I want you to know as well, we do have live help available throughout today's webinar. If you look in the lower right-hand corner of your screen, you'll see a toll-free number, 888-364-8804. You can call that and get help. In addition, underneath the slide, you'll see a box that's labeled Q&A, and you can type in technical questions or problems that you may be having with the audio or the slides or the website. And again, live help will be at hand through our people here at Blue Sky or CAP Today staff. But of course, most importantly, the Q&A box is there for you to pose questions and comments anytime during today's webinar. And as I mentioned before, after our two presentations and our two presenters have finished, then I will start a Q&A session and take us through as many as we can have time to discuss and vent. I want you to know we'll put the full slides and audio of this webinar up in about 5 days at captodayonline.com, and it'll be there for a good long time so you can review it again, share it with colleagues, and generally have that resource available. I want you to know that you can expect some follow-up emails after today's event, so that's an alert I think you should have. And finally, it's very important for me to say that the CAP does not endorse any products or services that might be named in today's webinar. And my own comments today are purely personal. They're not to be construed as policy of CAP Today or the College of American Pathologists. And with that, once again, I want to acknowledge Roche for their important role in helping to bring today's webinar to you. And so now, let me introduce our two speakers. Dr. Steve Miller is an MD, PhD at the University of California in San Francisco. He trained at Albert Einstein College in the Bronx and has done extensive work subsequently at UCSF. We're very glad to have him. But we'll lead off with our first speaker. Dr. Joseph Yao is at the Mayo Clinic in Rochester, Minnesota. He went to school at the University of Manitoba, did his residency at Mayo Clinic, and was a fellow in infectious disease at the Beth Israel Deaconess in Boston. He's well-traveled, and he's also a veteran. He's on the October cover of CAP Today, properly masked with his colleagues at the Mayo Clinic. And so it's a great pleasure to introduce and ask Dr. Yao to begin today's webinar. Dr. Yao.
Thank you, Dr. McGonnagle and CAP Today for this opportunity to speak about post-transplant viral load testing. In my portion of today's presentation, there are a few audience response questions that we appreciate your participation and your responses to others joining, and compare your responses to others joining this webinar. Let me start by presenting a case history of a patient in whom viral load testing highlight the challenges that clinicians and laboratorians face today. Here are my conflict of interest disclosure. This is a case of a 32-year-old man with end-stage lung disease due to cystic fibrosis, and he underwent bilateral lung transplantation 3 months ago with a CMV IgG serology positive in both the organ donor and recipient. The EBV viral capsid antigen antibody IgG was positive only in the donor but negative in the recipient. He presented to his local hospital with 2 weeks of fever, malaise, night sweats, decreased appetite, and nausea. At the time of examination, he was found to be mildly febrile with some jaundice with icteric sclera. He had enlarged palpable lymph nodes in the cervical region of the neck with enlarged tonsils, and there was some mild tenderness in the right upper quadrant of his abdomen. His laboratory test showed mild anemia, the white blood cell count of 4,100, platelet count 150,000, elevated aminotransferase levels to 105, and elevated total and direct bilirubin. The local hospital was able to obtain a CMV DNA in plasma of 55 international units per ml. They also had a send-out test obtained on EBV DNA plasma to an external laboratory with 5,500 copies per ml. And in the log transform units, it was 3.74 log copies per ml. So here's the first question for the audience. Does your laboratory perform EBV viral load testing? And if so, what specimen types is or are accepted for testing? Please make your selection. Okay, the poll is closed. And I'm not sure whether the audience can see close to half of the participants say that they don't perform EBV viral load testing in their laboratories. About a quarter say they do and using plasma only. And then there are also 23% who says that they test both plasma and whole blood. Okay, thank you. We can close that. And here's my next question for the audience. For those who do offer or perform EBV viral load testing, which of the following combinations of assay and unit of measurements apply to your laboratory? One is a laboratory-developed test using self-designed primers probes and results expressed in copies per ml. Second choice is same setup but express results in international units per ml. Third and fourth are lab-developed tests using commercially available analyte-specific reagents, but reporting results in either copies per ml or IU per ml. Or the final option is you are using a FDA-approved in vitro diagnostic assay, reporting results in IU per ml. Please make your selection. Okay, so poll is closed, and I think very interesting spread among the participants. Looks like 30% use commercially available ASR, reporting results in IU per ml, and then an even split between the ASR in copies per ml and also FDA-approved IVD results in IU per ml. Great, thank you. So let's continue with the patient's history. So this patient was transferred to a local transplant medical center for further evaluation because of the EBV test results obtained from the outside lab. And this time, the transplant center was able to perform their own EBV DNA viral load testing with a result of 85,500, or 4.93 log. And this transplant center lab use a laboratory developed assay with a commercial ASR. So the transplant service team was puzzled by the difference in the EBV viral load results between the local hospital where the test was sent out with 3.74 log and the local transplant medical center lab were a result of 4.93. So it was slightly over a 10-fold difference, or 1 log difference, between the original and the subsequent results about 3 days later at the transplant center. So here's my third question to the audience. What do the two quantitative viral load test results indicate to you? 1, you believe that the patient has infectious mononucleosis or primary EBV infection, or this patient has a post-transplant EBV-related lymphoproliferative disorder, known also as PTLD, or one of the two test results was erroneous, or both results were erroneous. Please make your selection. Okay, so the polls are in. So slightly over half of you believe that this patient has PTLD. Another group almost 30% felt that both tests were erroneous, and a small percentage think that this may be primary EBV infection. So we'll come back to this answer in my second part. So my fourth and last question is, what testing would you recommend next on this patient? 1, determine EBV serology status with these markers in this patient. 2, repeat EBV viral load testing with the assay at the transplant center in another 3 to 5 days to compare to the original transplant center result. Or 3, repeat DNA testing with a third assay expressed in copies per ml, since the first two results were also in copies per ml. Or 4th answer is to retest with another assay but result in IU per ml. Please make your selection. Okay, the poll is closed, and you can see on your screen that majority of you think that we should retest with the same assay at the transplant center 3 to 5 days later. Another largest group is to look at the EBV serologic status in this patient, since we know that he was negative at the time of transplantation. All right. I will then pass this on to Dr. Miller for his portion of the presentation.
Thank you, Dr. Yao. Just let me remind the audience they can make comments or ask questions whenever they'd like to in the Q&A box below our slides. Dr. Yao, I know we'll be discussing this case later on, and it was a wonderful way to lay out some of the diagnostic considerations here in these sorts of patients. And now I'll ask Dr. Miller to begin his presentation.
Hi, thanks very much for the opportunity to talk today, and looking forward to the discussion of Dr. Yao's case. I'm Steve Miller. I'm the director of the UCSF Clinical Microbiology Lab, and we have our full-service lab that we do testing on a variety of patients. Transplant patients are one of our major populations. We have a fairly large transplant center, and we do all sorts of organs and tissues, including kidney, liver, heart, lung, islet cell, various tissue types, as well as stem cell transplants for both adult and pediatric patients. And so this is a very complex patient population, and also draws from a large geographic area. We're serving not only patients in our local area, but also those in the region, throughout the state, and even across multiple states. And so coordinating their care is can actually be a big challenge. And so this is very relevant to the topic today, where I'll be talking about standardization of viral load testing in transplant patients and some of the challenges and some of the new data that's coming out in the field. My disclosures, consulting here for Abbott and Roche, and my talk will consist of a variety of sections. First, I'll talk about some of the challenges that we have when monitoring viral load in these transplant patients and illustrate this with a case presentation on BK virus. And then I'll talk a little bit about the development of reference material and how that has helped the field to standardize some of these assays, a bit about assay harmonization, and then an overview of some of the sample type and processing issues that we see in the lab and how to deal with some of those with a case presentation on this section for EBV. And then I'll finish up with some of the laboratory solutions and future directions that we're seeing in this area. So what are the challenges involved in transplant viral monitoring? And this is, primarily, as Dr. Yao mentioned, you have a patient who has received a transplant and you want to see, are they in fact infected with a virus and how are they doing in their course? In many cases, you want to detect this early to try to do something about it because these patients are, of course, immunocompromised in order to not reject the organ, and you want to make sure that they don't then develop a subsequent infection. So the viruses that can infect transplant patients are quite varied, and so that is the first challenge in the lab, is simply having the appropriate assays for them, because these patients, being immunocompromised, are susceptible to a variety of these. And many of these are human herpes viruses, such as cytomegalovirus, Epstein-Barr virus, human herpes virus 6, as well as HSV1 and 2. But there's also other categories, such as adenoviruses and polyomaviruses, such as BK virus. And so you have to have a fairly substantial menu in your lab in order to do this. And of course, each assay has to be validated, performed acceptably, and also monitored through time to make sure that the standardization and the quantitation are accurate. And so this is actually quite a lot of work to make sure that these assays are performing correctly. On the clinical treatment side, there's really few treatment options for these patients. There are some specific agents for CMV or adenovirus, although in reality, while they may interfere with viral replication, they rarely allow a highly immunosuppressed patient, such as a bone marrow transplant patient prior to engraftment, to actually clear infection. And so oftentimes, you're relying on the host immune system and their own cellular response to be able to clear. And so, you're trying to buy them time, essentially, by giving them antivirals. But in many cases, there are no effective antivirals. And the problem with treating all your patients prophylactically, which is done in some cases for high-risk patients, is that there's not only costly medicine to give, but also side effects. Notably, ganciclovir is marrow-suppressive, and so you really want to avoid giving that in these patients where you want their immune response to be as robust as possible. And so you're a bit stuck between a rock and a hard place in these patients trying to figure out what to do. What you can do in many cases is sort of dial up and down the immunosuppressive meds that you're giving. And here you're really walking a tightrope in terms of balancing this, because too much immunosuppression can lead to susceptibility to infections by viruses and other agents, bacteria, fungi, molds, AFB, but too little immunosuppression, and you run the risk of that patient actually rejecting the organ and having acute cellular rejection. And so either side of that is bad. You really have to strike a balance. And of course, knowing the state of your patient in terms of these infections is important. And so, one of the things that the lab is looked to do is to help to assess the patient. And this is a very difficult thing to do because oftentimes these viruses present nonspecifically. They may be a fever of unknown origin in a transplant patient. You really don't know much about what's going on. And so the lab result really does impact the management decision, and the change in the viral load is a particularly important parameter to be able to figure out what to do next with your patient. So this really is an important aspect of how these patients are managed. Now, it would be great if we could develop guidelines about how to manage these patients, how to perform viral load testing, and sort of apply them universally throughout the transplant population. But this is really not possible because of the variety of types of transplants and also the variety of individual patient situations that you have. The illustration of, with this case of, a patient whose CMV donor and recipient status are both seropositive actually changes the risk of that patient for development of CMV, for example. And so there's a lot of different factors that need to be taken into account, and makes it very difficult to establish a single approach or guidelines for how to do this. So this is an area of active investigation that really a lot more study and data need to come out in order to really guide how to best manage these patients. And finally, even if all of these weren't enough, there's a lot of technical challenges in developing good and standard and harmonized assays for virus monitoring. The calibration material is key, and there are a variety of sources and types of this. So, each assay may be calibrated or standardized to different material. It could be whole virus, it could be a partial genome, it could be nucleic acid fragments, it may be encapsulated or non-encapsulated. And that actually makes a big difference during the extraction process, and the efficiency of extraction can affect the overall viral load that you achieve at the end. And then these materials will perform differently across different assays. And so it really is a challenge to find a single calibrator material that will work across all different assay types. And so, this is really some of the major issues that we deal with in the field. So what does this mean? Well, all of this adds up to interlaboratory variability. In general, a single lab doing precision studies on the same sample will actually do pretty well over time. But if you see labs that are sent the same sample, so it's in this case samples A through G, you can see that there's a general correlation between the viral loads that are achieved in each of these. But here, there's quite a large spread. So there's, over 2 logs, 3 logs, even 4 logs spread of the viral load seen between different laboratories. And this variability is increased somewhat at higher viral loads, but it's still present at low viral loads. And so if you actually, switch labs, the amount, the quantitation, even in the same sample, can be quite variable. And that is one of the things that we're trying to deal with. So how do we deal with this? Here's a case study of a BK virus infection. This pediatric patient unfortunately had Wiskott-Aldrich syndrome, which is an X-linked recessive immune deficiency, and so received a stem cell transplant so that their immune system could be reconstituted with the donor. However, post-transplant, this patient had a number of complications. They didn't engraft well and unfortunately had prolonged cytopenias, leading to an elevated risk for opportunistic infections. Also developed an autoimmune hemolytic anemia, so there was some concern about the possibility of rejection in this patient. And so now you're really walking a very, very tight tightrope trying to manage this patient. Had multiple infections, including salmonella enteritis, as well as low-level CMV viremia that may or may not be clinically significant, but it is worrisome in a patient like this that it might start suddenly becoming a severe CMV infection. And then developed hemorrhagic cystitis due to BK viral infection. And so this patient was placed on cidofovir and leflunomide which are agents that can be used to treat BK virus, but the effectiveness of these, as I mentioned, is not great. And the treatment was really intermittent because there was some bone marrow suppression. And if you look at the plasma BK virus level over time, you can see that as they developed this hemorrhagic cystitis, their plasma BK viral level rose substantially from, negative to 4 or 5 logs up to over 7 logs. And then the patient transferred care, and in this red dot, we see a second result after 5 months, showing about 6.5 logs of virus in the plasma, which is a quite high level and is quite concerning. So here's the question in this case. What is the clinical significance of this latest BK viral load test? Is this a titer that's remaining highly elevated? We need to reduce our immunosuppression and hope that this patient is able to combat the virus with their own cellular immunity. Do we think the BK virus titer is stable? We're going to kind of keep continuing our current management. Or do we need to do another assay? Maybe we need to look at a different sample type. This has been done in plasma. What about in urine? And the fourth possibility, well, we really don't know what's going on with this. Maybe we need a repeat assay. So the poll's open, and let's see what people think. Great, thank you. The poll's closed, and there's a variety of responses here. There's, sort of fairly evenly split between this patient may need more immune suppression versus they're probably doing okay, let's continue and continue to assess. About a quarter were interested in the BK titer in the urine sample, and then, almost 20% said, well, we can't really tell, let's repeat the assay. And so as the patient was being seen at their initial transplant center, we actually arranged for samples to be sent to our lab, and shortly after their initial or their lab results, we were able to get a second sample, and that actually showed what looked like a substantial decline in the viral titer, about 1.5 logs, and then the following month continued to go down. And so this patient is actually on the right track. Now, you might consider, whether your immune suppression needs to be dialed up or down, and you're going to be looking at the, prevalence of immune, mediated activation, such as their hemolytic anemia. Is that getting worse? If it's not getting worse, though, you might want to consider staying on. Now, a number of people wanted to get a urine assay. We didn't do that in this case, and urine is typically more sensitive for the detection of BK virus nephropathy. In renal transplant patients, there's a lot less data about bone marrow transplant patients with hemorrhagic cystitis, but you do expect to see much higher levels in the urine than in the plasma. In general, I look at plasma as being a more specific assay and a better assay to assess the actual state of the patient than the urine. So I generally don't recommend urine testing for assessment of patients with known infection. Plasma generally will work better. But I do highly recommend that they test on the same assay if possible, especially if this patient is having a substantial complications and you really want to know, is it going up or down? And so this case illustrates the issues that we have between the variability between labs and how that standardization, if we were able to achieve it, might actually help in our management so that we wouldn't have to do, all sorts of sending samples between labs and the patients waiting and wondering what's going on. So how do we do this? Well, there is a reference material that has been developed for BK virus. This is WHO material that is basically consists of a whole cell virus preparation of BK virus that was cultured in cellular culture. And this material was then lyophilized and sent to a variety of laboratories for quantitation. And this one that was chosen was a genotype 1b2, and it's predominant in Europe and North America, but not necessarily other regions of the world. And that's an important point, that not all patients are infected with the same strain of virus. And so you need to consider both the material itself, which virus is chosen or which target is chosen, and also the assay. And if you look at these labs performed a variety of different assays on this standard material, and you see that, while they do harmonize reasonably well around the 7 log area, there is variability depending on the individual region chosen for targeting with the assay. And so that will affect, to some extent, the quantitation, whether you use a target on your assay that is the same or different than what was used to standardize. Now, the goal is, of course, to make this universal, but that is often difficult to achieve. And, one of the major reasons is, of course, the mutations that are seen across various genomes. And so this is just a table to show some of the differences in amplification efficiency that you get if you have primer mismatches across the genome. And you can see that a primer mismatch that is across the genome will affect the amplification efficiency. So compared to 0 primer mismatches, which is the reference of 100% efficiency, if you have 1 primer mismatch, in this case genotype 3, you get around a 10% amplification efficiency, rising as you get to low viral loads because it becomes a little bit less quantitative at this and more of a qualitative assessment. But that's a big difference. And if you have 2 mutants under their primers, you actually get very low efficiency, 1% or less. And so this is a real significant effect and is going to be a major contributor to the difference in viral load if you happen to have primers and your patient has a virus where it's mutants under that primer. Now, does standardization work? That's a big question for us. We all think that it's great, but how much does it actually help? Well, here is an example for Epstein-Barr virus, where you can see that even in the same assay across multiple different labs, if you standardize to use a single calibrator for these assays, you actually are able to get a little bit better variability between the labs, or less variability between the labs. So in this case, these dashed lines on the left are shown in individual assay copies per mil that are calibrated to a variety of different standards, whatever the lab happened to use. And when they calibrated them to a reference standard and then reported this as a calibrated value in international units per mil, the variability went down substantially. Now, it doesn't entirely disappear, but you can see that the results between different labs actually correlate better. So this does have an effect, and it can increase the confidence that you have that your result is meaningful, which is really what the clinicians want to know. Now, if we have sample type issue changes and processing changes, that can actually affect the quantitation. So, for example, this BK virus standard that I had talked about earlier was put into various clinical matrices, including whole blood, plasma, and urine. And you can see that the quantitation actually changed between each of these different sample types, with the urine having the lowest value assigned after the assay, and plasma having a higher value, almost a log higher. And so, while there was tight correlation, if you assayed the same sample type, the precision of these assays is quite good, but the matrix effect is actually substantial. And the reason for this is likely due to the extraction process. Now, as you assay these samples, you first have to extract the nucleic acid from whatever matrix it is it is in and then perform your amplification. And the extraction efficiency is going to be different for different sample types. So you have plasma, maybe having a higher extraction efficiency than whole blood or urine, which are more complex and have more different materials in them. And then if you look at automated versus manual extractions, you can see that the precision of automated extractions is actually better than manual extractions. And so we can do little things in the lab, like changing to automated systems, that will help reduce the variability in that assay. So here's a case study with Epstein-Barr virus. An adult patient with acute myeloid leukemia received a stem cell transplant following marrow ablation, and then 3 months later is developing fevers, and extensive infectious workup was done. It was all negative. Paraspinal masses were seen on imaging, and so there was concern for post-transplant lymphoproliferative disorder, and this mass was biopsied by fine needle aspirate, trying to get an answer. Unfortunately, the pathology only shows necrotic cell debris, so this is an inconclusive diagnosis. And so the plasma EBV PCR in this case was negative. Is there a role for whole blood EBV PCR in this case? So this gets to the sample type issue, and this is particularly important for Epstein-Barr virus, where you have oftentimes relatively low viral loads in detectable viral loads in patients, even with PTLD. And in general, I see whole blood as being a more sensitive matrix, where you're assessing both the cellular and the cell-free plasma compartment. And so you're detecting cell-associated virus. Now, plasma, however, is more specific for disease. And so while the levels in plasma are often lower than whole blood, detection in plasma is actually a better indicator that this patient may have PTLD or a significant infection. And if you compare individual assays for sensitivity and specificity of the diagnosis of PTLD, you see that the specificity in plasma is quite high, whereas in whole blood, the cellular EBV portion, it's running in the 80s, maybe up to 90%, and that's actually fairly problematic if you're using this as a screening assay, which is oftentimes done in these transplant patients. They're not necessarily evaluating this type of patient where they have a real suspicion, but they're just kind of monitoring them over time. And if you have an assay with a low specificity, that's going to be a problem because you're going to be potentially diagnosing many of these cases. So, of course, if the providers understand this and they follow up a whole blood with a plasma assay and are assessing both, that can be fine. Now, whole blood tends to be more sensitive here, and the sensitivity of this assay is not that great for detection of PTLD, in the 60s and 70%, sometimes even lower in plasma, but it can be improved by selecting the right assay and designing a good assay for it. So in general, the approach that our laboratory has taken has been to offer plasma EBV viral load testing as more specific, but in a patient like this that has a high index of suspicion, I would certainly want to do a whole blood EBV PCR because we don't do that standard in our lab with the send out, but it's something that we would do in this case, and in this case actually was positive and may help them make the diagnosis and manage the patient. So what are our solutions to doing this in the lab? Assay harmonization can be useful, as I showed a little bit about. Transitioning to standard material, such as WHO calibrated material, can be useful. You need to calibrate your standard curve for your laboratory-developed assay, if that's what you're using. If you're using a manufacturer-developed assay, those typically are often already calibrated, which is a nice feature of that. And you want to consider your assay workflow and process. If you can automate steps along the way, that will help improve your precision and reduce your variability. And you want to, importantly, develop sample type protocols. You want to assess how is this going to be used for your different transplant populations. There's often a trade-off between sensitivity and specificity for different sample types, and you need to really engage with the clinical services on this to make sure that they understand how you're approaching this from the lab and that really does impact how they think about these test results for their patients. And you need to be able to educate them as to what does the negative mean in this case, or what does a positive mean, and how do we manage it? Maybe we don't just jump to a diagnosis, but we really consider it in the patient situation, and over time, how do we manage them? In some cases, it can be hard to validate every virus for every sample type, and you may need to send things out, and that's okay. So the future directions that we're seeing in this field, one of them that's kind of exciting is calibration using a standard independent approach, and this is with the droplet digital PCR, where you can get an absolute copy number based on the volume assessed. And so this is starting to be used to develop reference material, and I think will be a very useful thing to have. Now, most labs are going to use commercial reference material, which is entirely appropriate, but having an absolute concentration rather than a relative sort of arbitrary concentration level, which is most agents have been in to date, I think that will help us to standardize these assays. Of course, the extraction portion is still a major issue for variability. So, and then metagenomic next-gen sequencing is coming out as a possible mechanism for monitoring these patients. You prepare your library, typically of cell-free DNA from plasma, and sequence it. The number of sequence reads can be proportional to the viral load, and if you add an internal calibrator or an internal control that's at a known concentration, you can actually get a relative level from your assay. And so there are novel approaches to this. And finally, fully automated assays that are pre-calibrated are important. But they still need validation of alternative sample types. So I will stop there, and there are a couple of questions that I think we're going to get to at the end, but I'll turn it back over.
Thank you. Thank you so much, Dr. Miller. And now Dr. Yao will resume his discussion. Dr. Yao.
Thank you. So let's return to the case. So this 32-year-old man with post-transplant EBV infection at the local transplant center actually decided to send a sample out to Mayo Medical Laboratories, which used a laboratory-developed assay with commercial analyte-specific reagent calibrated to a secondary EBV DNA standard, and the range of the assay is listed there and was expressed in international units per ml. So it was 4.88 log IU per ml, so quite different than the copies per ml from the original local hospital, but closer to the copies per ml done at the transplant center. So to make a long story short, this patient actually had undergone abdominal CT scan that showed these hypodense lesion in the liver, which is consistent and suggestive of PTLD. Now, of course, this was also a primary EBV infection transmitted by the donor organ. So for those who answer the question that this was a primary EBV infection, although it's not technically correct as an infectious mononucleosis, but it is a EBV primary infection leading to PTLD. And he underwent lymph node biopsy that ultimately histopathology and genetics testing showed that this was a polymorphic PTLD with early malignant transformation, showing also immunoglobulin gene rearrangement. So he actually underwent reduction in immunosuppressive therapy along with B-cell depletion therapy with rituximab with resolution of this transplant-related PTLD. So I'm not going to say too much about commutability, but for those who are maybe confused or still lacking a definition of commutability, I showed on the screen here that this is a ability of a reference material or control material for measurement of an analyte to have inter-assay properties that are comparable to properties of authentic clinical samples when tested by more than one assay. And that these material is considered to be commutable when the assay produces the same result as it does for authentic patient sample that contained this analyte. And so assays that are calibrated with these commutable reference material will produce assays for clinical samples that are equivalent among all these assays. So that means that these results are traceable to the reference system and that there is no calibration bias among the assays when such commutable reference material is used. So these are two good references for those who are interested in learning about commutability of reference material. Now, how does one determine the reference material is commutable? Here's a good study from almost 10 years ago now that looked at two different assays and two different material of CMV DNA. So the triangles represent clinical samples, the solid circles represent the OptiQuant CMV panel, and the gray square represent a different OptiQuant CMV panel. The solid line shows the trend, and then the dashed lines represent the 95% confidence range, 95% range of the results generated. So you can see that the OptiQuant CMV panel in solid circle closely mimic what results were generated on clinical samples. The gray square falls in the 95% range that mimic closely with clinical samples, whereas the solid circle, the OptiQuant CMV, matches less compared to the OptiQuant CMV TC panel. So one would prefer to use the OptiQuant CMV TC panel represented by the gray square as the more commutable reference material when one is testing by these two different methods. We actually also can see from this study involving 5 medical centers and laboratories with 5 different assay protocols for measuring CMV DNA in plasma. So here they compare 5 assays with 2 panels, a commercial available CMV DNA panel and the WHO international standard. You can see that at the 4 different levels of these panels, the maximum differences between the 5 protocols are indicated in red. So this commercial panel did not show much difference among the 5 protocols at these 4 quantification levels. And similarly with the international WHO standard, these 5 assays using WHO standard also show minimal variations. So ideally, we like to see the maximum difference less than 1 log between the highest and the lowest results generated from these different protocols. So this means that these both panels, the commercial and WHO, are commutable among these 5 assays. Now, when you look at the EBV panels, we see actually a lot more variability using the commercial panel as well as the WHO international standard. So the current WHO standard is not foolproof, and we still have a lot of work to do to improve the commutability of the different reference materials for different assays currently in clinical use. I thought it would be interesting for us to also look at the most recent CAP viral load proficiency survey in June this year. you can see that for CMV, all 298 participants' laboratories are now officially reporting results in IU per ml. A lot of laboratories, almost 90%, are still using ASR. 35 of them are using LDT. For EBV, it's half and half. Half are reporting in copies per ml and half in IUs per ml. And then for BK virus, it's the other way around. It's a 30-70 split. And then adenovirus currently has an international standard, but for the 60 laboratories participant, they're only reporting in copies per ml. And HHV6 also has a WHO international standard, and so far, no one is reporting in international units per ml at this time. So finally, I want to conclude by saying that laboratories should use commutable reference and control material that are traceable to the WHO international standards for assay calibration. So current WHO standards are available for adenovirus, BK virus, EBV, HHV6, and CMV. So also the assay would be best to calibrate it to such WHO international standard. And also, even when assays are calibrated to international standards and using commutable reference material and controls, it is still advisable because of variability from one assay to another. It's still advisable to monitor viral load results over time in any given patient using the same assay. So I'll end there and turn over to Dr. McGonnagle.
Thank you. Thank you very much, Dr. Yao. I do want to thank you and Dr. Miller both and remind our audience that there's still time to make a comment or ask a question. And I thought this is a very nice little ending here. Obviously, COVID's been much on our minds. So if I could ask you to begin, Dr. Miller, give us a brief comment or two about the impact of COVID-19 on post-transplant diagnostics in particular.
Sure. Yeah, I'd say there are a couple of different major effects that it has had. One of them being in the sort of immediate transplant period where these patients have organs that are waiting for them to be transplanted essentially on ice, undergoing cold ischemia, and they need to get rapid results. So we've had to develop mechanisms for getting very rapid results for these patients in the operative period. In the post-op period, I think the main challenge has actually been access to care and getting these patients appropriately monitored and tested. These patients are at higher risk of bad outcomes due to COVID-19, but in many cases they're sequestered and not really coming to care as much, if at all. And so it's one of the things that we've had to do is work with our transplant units to develop protocols for testing of these patients when they come in for certain types of procedures. And that's been an ongoing issue. We started primarily doing testing for aerosol-generating procedures, and these patients were sort of rolled into that. But for many of the patients, coming in for chemotherapy on the bone marrow transplant side, and they're wanting to basically have a safer environment for both the providers and the patients. And so being able to screen these patients has been and get the results rapidly has been one of the major effects for COVID-19.
Thank you. And Dr. Yao, the same question. What has been the impact of COVID on post-transplant diagnostics?
Yeah, at our laboratory and our medical centers, the immediate first month or so impact has been drastic reduction of the number of requests for testing, mainly because patients are not returning to our medical center for their monitoring post-transplant. So, in fact, all our transplant surgery was discontinued for the first month into the epidemic here in the U.S. So our immediate post-transplant testing has been reduced, but those who are on their monitoring 2 or 3 months after transplant also has decreased. So we have seen a decreased demand, and now about 4 months after the pandemic started, we're gradually seeing patients coming back and also increasing our transplant surgical patient load to not quite pre-COVID levels, but almost 70–80%. So we are seeing the demand back, but the problem now we face in the laboratory is lack of supplies from the assay manufacturers, because a lot of the same reagents and consumables are being used and diverted for COVID-19 molecular tests because they share the same material and the consumables. So we're on allocations, and we are fortunate that we're still able to keep up with the clinical demand. But we hope that things will improve over time as the IVD manufacturer increase their production capability.
Thank you. Thank you very much. And Dr. Miller, just one quick comment on supply chain as it affects post-transplant diagnostics at the moment.
Yeah, I'd say the biggest impact was actually in the LDT area on the extraction side, because many of our assays were using the same extraction platform that our transplant virus assays were using, and so that became a real crunch for us, especially in the early stages of the pandemic when it hit, and so we really had to. The volume did ramp down, but we still had to maintain enough supply to manage our transplant testing while still ramping up our COVID testing. So that was a major challenge. Now that there are more high-throughput IVD instruments and assays out there that don't require separate extraction, we've moved somewhat away from the LDTs for COVID. We still use them as backup methods, but our primary methods are now kind of large-scale, high-throughput instruments. So we're hoping that we don't get to the point where we have to go back to our backup methods. It all depends on what the manufacturers are able to provide and what happens in terms of the scale of the scope of the pandemic.
Thank you. Thank you very much. And now let's return to our questions around standardization and commutability in post-transplant viral load testing. One of the things that leaps to mind immediately is trying to further segment these transplant populations, partly by organ, partly by some consistent cohorts within the transplant population to establish some performance and some reference ranges. Will commutability be an absolutely essential factor to have if we're to attain that sort of greater understanding? I'll ask you first, Dr. Yao.
Yes, I think that will become increasingly important, especially if one is going towards FDA approval for commercialization. I think the FDA personnel are very attuned to the commutability issues with these IVD assays for viral load monitoring. So I think it will increasingly become important. And also, the users are becoming increasingly sophisticated and knowledgeable and wanted to demand these quality measures be in place for commutability.
Thank you very much. And Dr. Miller, your comment on that same question.
Sure. Yeah, and also there's a great question from the audience about how you determine cutoffs for your population that's applicable to this. Because commutability is certainly important and is going to help us develop these cutoffs and these thresholds between different labs. Now, when you're doing this in your lab, the first thing that I would do is go to the literature and try and see, okay, what's been known about cutoffs, and discuss with your transplant teams and clinical providers how they are managing their patients based on these cutoffs. It is possible to determine cutoffs in your own laboratory with a study, but it's quite challenging, and I wouldn't expect everybody to be able to do it. For example, for BK virus, we did a study where we correlated the pathology-confirmed cases of BK-associated nephropathy with the BK viral load in both plasma and urine. And we saw that there was a pretty good correlation between those patients who had developed polyomavirus-associated nephropathy and a plasma viral load of about 10 to the 4th copies per mil. The correlation was higher in urine, about 10 to the 6th copies per mil, but it was not quite as good as plasma. So we use that as sort of a internal threshold for when we think this patient actually has pathology diagnosable BK nephropathy. Now, the problem with that is that that threshold is really too late. You don't want to just know that your patient has bad BK nephropathy. You want to be able to prevent it. And what we really need are studies looking at different treatment options or different changes in the immunosuppressive regimens based on BK viral load testing, and potentially using a lower level to modify or decrease the immunosuppression in those patients. Problem is, BK is a very common virus, and most people are seropositive, and a large majority of these transplant patients have detectable BK, especially in the urine at low levels. And so you don't want to be treating everybody. And so I think, you have to think about not only, what are your cutoffs and what are your thresholds, but what is your relevant clinical metric and that you're using to make a decision. So I think we can have some good metrics for associations, but we're still waiting on metrics and thresholds for some of the treatment decisions in the early stage. CMV is a little different in that you don't expect to see it in most of these patients, and so any level is concerning in a highly immunocompromised patient. We have the separate problem of when to stop treatment in those patients, where we often want them to get 2 negative results in a row. And so, it does get to be challenging, and I always recommend, discussing these potential thresholds and how they're implemented with your providers, because that's going to be the most important thing.
Yes, thank you very much. And Dr. Yao, I'd like you to follow up and comment on what we have just heard from Dr. Miller regarding your approach to cutoff values in different populations for different viruses.
Yes, that is very relevant, and it's a difficult one to establish for multiple reasons that Dr. Miller has stated. One is the cutoff may be different for different organ transplant recipient population. It may be a different cutoff for those who are mismatched versus those who are matched, like the D positive, R positive versus D positive, R minus. So the higher risk individuals may need a lower threshold, and the high threshold may be too late to diagnose the disease, as Dr. Miller indicated. But also differences in assays, variability from one center to another, and also the performance of the assay, whether it's reproducible. So at our centers, we have to validate this threshold for our own patient populations and subpopulations using the assay that we use. And such threshold is not necessarily applicable for another center who may use a different assay or different reference material.
Yes, thank you very much. In fact, that very questioner raises the question whether clinical correlation from in-house studies amounts to IQCP for viral cutoffs. Would you agree with that for your particular in-house studies?
Yes, absolutely. Yeah, one will have to establish that IQCP for user-specific assay for the in-house population.
Yes. And Dr. Miller, the same question. Could that amount to an IQCP for your in-house population?
Yeah, I think it's going to depend on how that's being used. Most of these thresholds are sort of a little loose at this point. It all depends on the patient situation, and because there are so many different assays out there and there's relatively few standardized, it's getting better, but the studies are really not universal at this point. And so I would say that, depending on how you're using these assays, you may want to include, some assessment of the threshold level in your IQCP, but that's going to depend on really, how that's being managed in your clinical population.
Thank you. So let me
it's
ask
important
you,
to.
yes, go ahead,
it's
Dr.
also important to realize that it's not a single value that's important for patient management, but also the serial levels. Is it going up or going down over time? Mm-hmm. That dictates what needs to be done with the patient.
Yes, thank you very much. And that brings us to a question, I think, which I will have as the last question. This regards the FDA, and so you may or may not be completely versant with this, but the question is as follows. Doesn't FDA require dual target PCR schemes for viral load detection for the purposes of an IVD designation? I'll ask you, Dr. Yao.
I'm not aware for viral load monitoring that dual target is a must.
Okay.
I think it's really up to the manufacturer to show that they can amplify equivalently among different strain variants to show that they don't have any bias. So obviously, we know that DNA viruses tend to have less strain-to-strain sequence variability versus RNA viruses such as HCV or HIV.
Yes.
But currently, the HIV is a dual target for some of the IVD assays. HBV and HCV, I believe, are single for many of the IVD assays. But the latest EBV assay that was FDA approved in August had a dual target for EBV, but I don't believe it's a must. It's just that the manufacturer has to show to the FDA that they don't have under-quantification for one strain variant compared to the other.
I understand. And so that would be part of the filing that the manufacturer would make with FDA in the application.
Correct.
Dr. Miller, would you care to comment very quickly on this question?
Sure. Yeah, no, I completely agree. It really depends on the manufacturer's submission and the choice of target. I think there would need to be strong data showing that whatever target is chosen, whether it's single or multiple, is conserved among known strains and is in a region where you expect that sequence to be conserved over time, because the main concern is really, different strains having mutations at the relevant primer and probe regions. So I think if you can demonstrate that sufficiently, then a single target may be enough. But, if not, or if you want to cover your bases, some manufacturers may choose to do multiple targets.
Very good. Thank you very much. And with that, I think I'll give you the last word. I think it's about time to wrap up. We're well past the top of the hour. This has been a very rich presentation that you two have put together. And as I said at the beginning, this will be posted, all the slides and audio, on captodayonline.com in 5 days or so. I'm sure many of us will want to have a chance to review and see this once again and share it in particular with colleagues who were not able to attend today. So with that, let me begin to wrap up. I'd like to thank Dr. Steve Miller of UCSF, and Dr. Joseph Yao of the Mayo Clinic in Rochester, along with an acknowledgement and great thanks to Roche for their special educational grant that made this webinar possible. And finally, I'd like to thank all of you who took time out of a very busy lab day in a busy and rather hectic week to join us for this webinar. It means a lot to us that you find them valuable and spend some time with us and our distinguished speakers in these. So I thank all of you in the audience for that. So as I wrap up, let me once again thank Dr. Steve Miller, Dr. Joseph Yao, Roche, and all of you. And with that, I will bring today's webinar to a close. Thank you.